Welcome, everyone, and thank you for joining our webinar on strategies to prevent heart attack and stroke in the workplace, findings from the Workplace Health in America survey. This is part of the Make Wellness Your Business series of webinars and is a product of the Centers for Disease Control and Prevention's Workplace Health Resource Center. My name is Rhonda Robinson, a Karna LLC contractor in support of the CDC Workplace Health Program, and your moderator for today. An archived version of the broadcast, including the slides, will be available in a few weeks through the CDC Workplace Health Resource Center, cdc.gov/WHRC. Please take a moment to read our standard disclaimer. Our first presenter is Jason Lang. Jason is team lead for CDC Workplace Health Programs. Jason has managed projects and provided leadership for the CDC National Center for Chronic Disease Prevention and Health Promotion's Workplace Health Initiative since 2007. His responsibilities include strategic planning for worksite health promotion. He serves as a coordinator for the center's divisions and a workplace health liaison to other CDC centers. Our second presenter is Sharda Shantharam. Sharda is a health scientist with IHRC, Inc., supporting the Division for Heart Disease and Stroke Prevention at CDC. She focuses on legal epidemiology, developing assessment protocols, and translating and disseminating research to prevent and manage cardiovascular disease. Sharda became involved in workplace health promotion in 2014 when she examined state workplace health promotion policies. She has continued to translate evidence-based worksite wellness practices for the public. During today's webinar, we will cover the following agenda. Jason will start with an overview on the burden of heart disease and stroke and why employers and employees both should be focused on the #1 killer in the United States. He will then describe the CDC Workplace Health in America survey. Sharda will present specific findings from the survey focused on the questions related to heart disease and stroke prevention in the workplace. Jason will conclude with an overview of CDC's Workplace Health Resource Center. Now, I'd like to turn it over to Jason Lang to kick off our webinar.
Thanks, Rhonda. Many of these statistics are familiar to us. Each year in the United States, more than 1.5 million people have a heart attack or stroke, and more than 800,000 adults die from cardiovascular disease. Cardiovascular disease is the leading cause of potentially preventable death in the U.S. And cardiovascular disease is the greatest contributor to racial disparities in life expectancy among African Americans, accounting for more than 1 year of the almost 4 years shorter lifespan. So heart disease and stroke, as the #1 and #5 cause of death in the country, respectively, are top public health priorities. Here we see a January 2017 research article by Mensa et al. In the journal Circulation that depicts the rate of decline in the death rate for cardiovascular disease in green, coronary heart disease in blue, and stroke in red. Over the last 65 plus years, we have enjoyed considerable public health success in preventing heart attack and stroke deaths. What is alarming, however, is after 40 years of steady improvement, the rates of decline in both heart disease and stroke deaths have recently slowed. The CDC Division for Heart Disease and Stroke Prevention and Million Hearts initiatives are focused on priorities and strategies to reverse this troubling trend. We know, too, that cardiovascular disease risk increases with age. At age 24, one's risk for CVD is just 20%. At age 45, the chances of developing CVD more than double to 50%. And at age 65, the risk of CVD is 80%. These high-risk groups are all of working age. Approximately 80% of 25 to 54-year-olds are employed, and 37% of those 55 and older are employed. And despite millennials now comprising the largest generation of workers in the U.S. workforce, workers at higher risk for CVD, such as boomers and Gen Xers, remain the majority of the workforce. The cost to individuals, employers, and the U.S. economy as a whole is staggering, as more than 1 in every 7 healthcare dollars are spent on cardiovascular disease, translating to nearly $300 billion every year in medical costs and lost productivity. But if we can keep healthy employees healthy and prevent cardiovascular problems from developing or better manage these conditions for those who may have developed them, there are ample savings available to employers and their workers through wellness programs. The high cost of heart disease and stroke, both in terms of human life as well as economic loss, coupled together with a setting where a large population of high-risk individuals can be reached with cardiovascular health promotion and prevention programs, makes the worksite an ideal setting to impact the health and well-being of workers and the bottom line for businesses. I'd like to turn for a moment now and describe the Workplace Health in America survey and how it was developed. The Workplace Health in America survey is the first federally funded nationally representative survey of U.S. employers in over a decade. We set out to describe the current state of workplace health promotion and protection programs and practices in the U.S. In doing this, we sought to lay the groundwork for ongoing surveillance of these issues, widely disseminate the findings from the survey, and provide data to researchers and practitioners in the field to advance intervention and practice-based research. We had wide-ranging input from inside and outside of the federal government. We reviewed more than a dozen surveys of similar scope to construct the Workplace Health in America survey, and once we had drafted the survey, took steps to test and pilot it before full-scale data collection. Workplace Health in America is a very broad and comprehensive survey covering all of the content areas listed here. For our discussion today, we'll be focusing on data related to heart disease and stroke, which is related to the health promotion program area topic, as well as health screenings, disease management programs, and health insurance. Because of the size of the survey and the total number of items, we broke the survey into a core set of questions and a set of supplemental questions. After completing the core, respondents were given the option of continuing to the supplemental questions, which covered several additional health topics and emerging issues as examples. As I mentioned, we reviewed more than a dozen earlier workplace health surveys in developing Workplace Health in America, including the 2004 National Worksite Health Promotion Survey, which before Workplace Health in America was the most recent government-sponsored survey. We included many questions from that survey so that we could track and trend changes in practice over the last decade or so. We drew our sample from the Dun & Bradstreet database, which represents all U.S. employers with at least 10 employees. We set up our sample to be able to create estimates for geographic region as the primary level. These regions are multi-state areas where CDC coordinates many state-based health promotion programs. Within each region, we additionally generated estimates based on employer size and industry sector categories, based on a proportional allocation to the population. We initially screened employers for their eligibility to participate and also to identify a primary point of contact, ideally someone knowledgeable about the wellness program to respond to the survey. We provided multiple modalities to allow for survey completion. 86% of all respondents used the web mode. The survey took approximately 40 minutes to complete, and we collected data for nearly a year, beginning in November of 2016 and ending in September of 2017. We started with more than 35,000 employers. We found more than 4,700 were ineligible because they did not have at least 10 employees and or they had not been operational for at least 12 months. If we could not confirm a worksite was ineligible, it was considered eligible. We received over 3,100 responses to the survey, but we only included 2,843 in our final sample, which we considered complete surveys, meaning that the respondent had to either 1, provide a valid yes/no response to the key base question, do you have any type of health promotion program, or 2, provide a valid response to at least 50% of the applicable items after the base question. Of these, 44% completed both the core and supplemental questions. Estimates with a sample size of 30 or less, or where the relative standard error was greater than 30%, were deemed unreliable, and that data has been suppressed and is not presented. Now that you have a bit of a feel for what the survey is and what it covers, I will turn it over to Sharda to walk us through some of the results.
Thank you, Jason. So yes, let's go over some of the results. I'll start broad with some of the general workplace health programming at the national level, but spend most of my time going over the results as related to heart disease and its associated risk factors. And we'll look specifically at employer sizes and geography today. So we found that 46% of all employers had some type of health promotion program, which could be something like a walking club, diabetes education classes, or even on-site flu shots. We know from research that a comprehensive program is the most effective approach to building a wellness program, one that is sustainable and achieves the health and economic outcomes that employers want. A comprehensive approach looks to put interventions in place that address multiple risk factors and health conditions, and recognizes that the interventions and strategies chosen influence multiple levels of the organization. Our survey found only about 12% of employers have all 5 elements of a comprehensive program. So that means having a supportive social and physical environment, linking to related programs, having a health education program, integrating health promotion into the organization structure, and also offering some sort of health screening program. You can see that the supportive social and physical environment element is the most common among employers. This can include tobacco use bans or having walking trails around the office. Screening is the least common element, but I will get to that in a little bit. We also found that employers who have had a wellness program for more than 5 years are 3 times more likely to have a comprehensive program than those with shorter programs. Seeing that less than half of the employers have any one of these elements shows that as a community, we still have a lot of work to do. One way for employers to build comprehensive programs is to dedicate more resources to the program. Looking at budgets, of that 46% of employers with wellness programs, 36% do not have an annual wellness budget. We asked employers generally what their plans are for the wellness budgets in the next 12 months, and almost 80% said that they expected their budgets to remain about the same. So think about this. Experts recommend spending between roughly $150 and $300 per person annually to get the most impact. Roughly 2/3 of employers are spending $20,000 or less on their wellness programs. That's about $100 per employee, clearly below the recommended $150. Once again, we can see an opportunity for employers to increase their investments, just a little bit, to see an improvement in employee health. And you'll see in the next couple of slides that while many employers don't spend a lot of money on their wellness programs, small and large employers alike are still doing something to improve the health of their employees. So let's jump back to that screening idea where only about 27% of employers provide health screenings. We broke down our results by the number of employees and compared smaller businesses to the medium and large ones. That's the 100+ category. You can see in this slide and the coming ones that there's a trend. As businesses get bigger, more of them are providing health programs and services. High blood pressure or hypertension and cholesterol are among the most common risk factors for heart disease and stroke. And so in the survey, we asked about the level to which employers were screening for them. You can see that blood pressure is the most commonly screened for condition, and cholesterol is not far behind with roughly the same rate as any other condition, such as diabetes, obesity, cervical and colorectal cancer, etc. So when we compare small employers to those with 100 or more employees, you can see a much larger difference. Keep in mind that larger businesses typically have more resources to offer their employees. And blood pressure screenings may be more common because they're cheaper and they can be easily offered on site and don't require lab work for blood draws like some other screenings. And with heart disease being the #1 cause for death in the country, seeing employers identifying individuals with high blood pressure through their wellness programs is good news. So looking at the screenings from a geographical perspective, we see more blood pressure screenings occurring in the central region of the United States. Within Nebraska, Iowa, Kansas, and Missouri, those are the green states, 35% or more of employers are offering blood pressure screenings. The southern and southeastern region of the states from New Mexico to North Carolina, the orange states, are also seeing at least a quarter of employers offering screenings. Keep in mind that these are not state estimates. We took a regional approach to this question, so it may be that the actual rate in one state within the region falls outside the range for the entire region. Taking a look at cholesterol screenings, once again, employers in the central region offer screenings between 25 to 34.9% more than any other region. This is fairly consistent with the blood pressure screenings, with cholesterol not quite as common. While 15 to 24.9% of employers in the majority of the states are providing cholesterol screenings, it's interesting to see the southeastern region as one of the top providers. We saw the same with blood pressure. This area contains what is known as the stroke belt, where strokes occur more than 10% higher than the national average. Several initiatives from top organizations, including the CDC and the National Institutes of Health, have targeted this region in particular. So it's really encouraging to see that employers are also trying to identify high-risk employees in these states. Let's shift to employers who are providing referrals for their employees. The Community Preventive Services Task Force is a top public health organization that provides evidence-based recommendations for interventions aimed at improving population health. In 2007, they recommended pairing health screenings with feedback to change employee health as a best practice. This could be referrals for treatment or follow-up education and counseling. In terms of high blood pressure and cholesterol, we can see once again, high blood pressure is taking the lead, even if not by much, among small employers. However, these numbers are still low, and so we're not seeing much success with referring employees once their high risk factors are identified. Even the largest employers are doing it less than half the time. So again, there are more opportunities for employers to help their employees. So if screening and referrals lead to identifying an employee at risk for heart disease, employers can help their employees with keeping the condition under control through disease management programs. We found that less than 20% of all employers offer disease management programs for any condition, and most, almost 70%, with a disease management program are using multiple methods, including both distance-based and in-person, to engage and provide assistance to their employees. For employers with these types of programs, 19% target heart disease management assistance. So as we continue to see a shift in the nature of how work is done in the U.S., like telework and shift work, employers will likely continue to rely more and more on multiple approaches to offering these types of programs. And disease management program can range in intensity from providing information through brochures and videos to coaching and counseling sessions. This slide shows that the level of disease and risk management information dissemination is on par with the rates we've seen for screening and referral, meaning there is still plenty of room for improvement. This is one of the easier and cheaper ways to impact employee health, but it's not being done to a high degree, so there's plenty of room and opportunities here. And so working through the continuum of prevention strategies, we started with primary prevention through screening to identify employees at high risk for heart disease. Employers can build their programs to include secondary prevention by referring those with high risk for more education and treatment. And lastly, employers could end with tertiary prevention strategies through coaching and counseling sessions designed to teach participants skills on how to make healthy lifestyle choices, such as exercising more, proper diets, or managing their medications correctly. Here we asked if employers were providing one-on-one counseling or coaching sessions as a follow-up to their screening. Small employers, those with a 10 to 24 employees, rarely include these kinds of sessions in their wellness programs. The strategy is one of the more intensive methods, so we didn't expect to see a lower rate. However, it is one of the more effective strategies, certainly more than providing brochures. I do want to mention that the cholesterol sessions among employers with 250 to 499 employees is data with fewer respondents, so that data has been suppressed. So I'll end my portion of this presentation with this slide and some additional strategies to prevent heart disease for employers. In addition to education, screening with referrals, and counseling, workplaces can also make policy environmental changes that can positively affect heart disease and stroke outcomes among their employees. If you remember, almost 48% of employers have some sort of social and physical environment component to their program. These kinds of strategies usually come at little to no cost to implement. So things like providing blood pressure cuffs, having maps of measured walking routes, or making the majority of the choices available in cafeteria healthy ones are supportive strategies for employee wellness. If there is one message to take away from this presentation, it would be that the most effective approach is to blend individual risk reduction with policy and environmental supports. This will lead to healthier lifestyles, creating an evidence-based and comprehensive health promotion program. If you can provide the 5 elements I mentioned before, a supportive social and physical environment, linking health promotion programs, offering education programs, integrating health promotion into your organization's structure, and offering screening programs, then you're going to make a great impact on employee health. And from the data and strategies I highlighted today, there are plenty of opportunities for improving employee heart health. And so with that, I will turn it back to Jason.
Thanks, Sharda. Knowing which evidence-based strategies employers can use to promote healthy lifestyles and reduce heart attack and stroke among employees is very important. However, knowing and doing are 2 separate issues. CDC has developed a one-stop online database to help employers launch or expand a workplace health promotion program, which contains hundreds of evidence-based, credible resources all in one location, called the Workplace Health Resource Center, or WHRC. The WHRC database currently has over 500 workplace health specific resources, with more than 20 focused just on heart attack and stroke prevention, and that list will continue to grow. The free website includes case studies offering real-life examples from organizations of different sizes, resources on emerging issues such as improving sleep quality to address health and safety at the worksite, workplace health strategies tailored specifically for the needs and issues of small business, evidence-based summaries and issue briefs, and a suite of webinars and videos that provide training, testimonials, and promotional material. This easy-to-navigate website and searchable database helps employers find actionable workplace health information, guidance, and tools to develop or expand their workplace health promotion programs. Bookmark the Resource Center website at www.cdc.gov/WHRC as new resources are added regularly. And again, this is where we will post the archived version of today's webinar, including the slides, as well as a companion issue brief highlighting the heart disease and stroke data from the Workplace Health in America survey. Stay connected by checking www.cdc.gov/WHRC to learn about new product updates and upcoming events. Follow us on social media to get the latest news and updates via Facebook, Twitter, and LinkedIn. And finally, if you have any follow-up questions from today's presentation, please email workplacehealth@cdc.gov.
That concludes today's webinar. Thank you to our presenters, Jason Lang and Sharda Shantharam. And thank you, everyone, for joining us today. We appreciate your interest in workplace wellness. On behalf of the CDC Workplace Health Resource Center, thank you all for participating, and don't forget to make wellness your business. Have a great day.